but I will certainly expound on anything. And if people have questions as we go, by all means, I'll be happy to do that as far as to answer. Do you have the ability to go to the next slide?
Yes.
Okay, all right. So we've talked a lot about attention deficit disorder, and I feel as though for most people, it's a topic that they feel that they know most of the information, and there's not a lot left to talk about. But I'm going to mention a few things today that I think are worth noting, particularly those people who are doing assessments of children and adolescents, and also those who are going to be prescribing some medications. The prevalence of ADHD, these numbers will vary over time. People will say that years ago, ADHD didn't exist. There were just some hyper kids and they gave them a cup of coffee in the morning. But over time, we feel as though there probably are somewhere between 3 and 10% of school-age children. Many people put it at around 5%. And that will vary depending on the location. Some areas seem to have a higher percentage, or at least a higher percentage of those who are diagnosed. 2 to 7% of adults also appear to have that, and that may present as a residual effect of having had ADHD as a child or an adolescent. I will point out the fact that it is not an adult acquired disorder. There are individuals who will believe that they have attention deficit disorder. Sometimes it's because they have other conditions or other problems that do affect their attention, sometimes their motivation, their completion of tasks, and they come seeking either treatment or possibly medication. Overall, it's important to remember that you're not going to have a diagnosis of ADHD if you didn't have it in childhood or adolescence. And that's why I point out the fact that it isn't, although people will say I have, quote, adult ADHD, it's not a separate diagnosis. It simply represents the involvement of the diagnosis. In a clinical setting, such as we might see in outpatient or some of the community mental health centers, or those of you who are clinicians, in a typical clinic setting, it's far more males, typically 9 to 1 in a clinic setting. And it's interesting because I think that to a certain extent that represents boys who tend to be a little bit more of the hyperactive type, are brought to attention because they're having difficulties with behavior in school. And so they are more likely than perhaps females who may not have as much of the behavior component, or who are primarily inattentive type and who don't get noticed. I think that there's probably a tendency to question males' behavior and attention and attribute that to attention deficit disorder by providers of education and other care providers. In the community, however, the ratio is about 3 to 1, so certainly not as notable. Adults, when you see them in clinic, it's pretty much 1 to 1, females and males equally. And in the community, it's about 3 to 2. The persistence is about 50%. Years ago, people believed that ADHD was something that you grew out of. And in fact, I can remember early in my training that when people got to high school, there was a tendency to go ahead and taper and discontinue their medication, thinking that by this time their brain would have matured, they wouldn't be as hyperactive and behaviorally disordered, and that they no longer needed the medication. Over time, we realized that that's not really true, and that individuals who were taken off medication then went on to struggle if they were in later years in high school or college, or even in adulthood. And so we recognize that that's not the case. I will say that there are some adults who go on to function fairly well and will say that they don't take as much medication. I actually saw a former patient of mine that I hadn't seen in about 8 years for an evaluation on Monday. She was presenting for another issue, but she brought up the fact that, I probably shouldn't have ever gone off of my medicine. And she said that when she got to high school, she didn't feel that she needed it. She's an adult now and working, and she says that she realizes she has the same symptoms, many of the same symptoms that she had when she was much younger. And when I asked her why she, had not sought medication, she said she was embarrassed, that she thought it was something she should have outgrown. But in talking with her, I think that she's probably going to seek further evaluation and probably medication as well to help her in her everyday life. Okay, the next slide. Okay, so comorbidity. I think that you will occasionally see a child who has strictly ADHD. But by the same token, when you have a child who has it, I think it's important that you look at some other possible diagnoses. And the flip side would also be true. When you have certain disorders, it's important that you evaluate in all areas, and that includes attention span as well. The most common comorbid conditions that we see with attention deficit disorder are disruptive disorders and learning disorders. Um, they're not exclusive. And so sometimes we'll have kids who are acting out and they really will not have, or it won't be realized that they're actually having difficulties paying attention. And that they are disruptive because they can't pay attention or they are hyperactive, but it's only been attributed to that. And with some further evaluation, we realize that there's other conditions. Learning disorders are particularly important to target because they very much affect academic progress. Particularly some of the older kids in middle school and high school, if they're having difficulties in school understanding or reading is a huge learning disorder that will often present as kids being disruptive or not paying attention when in fact they're actually struggling and may be too embarrassed, or the learning disorder itself has been so significant that they've not recognized that there's an attention span problems. But other disorders include anxiety, depression, substance use, bipolar disorder, tics, including Tourette's, and even disruptive mood dysregulation disorder. Again, these are disorders that may come to your attention for various reasons, either because they've come to clinic or because they presented on an inpatient unit. Um, but one of the things that's always important to look at is the possibility of other conditions. Anxiety is one that can often mimic ADHD and will sometimes be diagnosed incorrectly as ADHD and not anxiety. Um, Kids who have anxiety will oftentimes not pay attention well. They may be fidgety, and they may present with all the symptoms that have made someone else, such as a teacher or an educator, think, oh, they're squirmy, they can't sit still, they don't pay attention, and we need to refer them for an ADHD evaluation. That's why it's always important to take a look at that. One of the interesting things with respect to that, I currently have a patient who's actually on my inpatient unit. She was referred for other reasons that relate to depression, but she also has anxiety. And in talking with her and her mom requested that I, quote, test her for ADHD. And in getting some more information, the reason for this is because she has not been paying attention very well during this time away from school during the COVID quarantine. She's not been as motivated. She hasn't been getting work completed. And in asking them, has this been a longstanding problem? The issue was no. This seems to have been something that has occurred during the course of this 2-month time that the kids have been out of school. She's a 16-year-old with no prior history. And in talking about this more, it seems that she is an anxious person. She feels very uncomfortable in this unstructured setting where she's responsible for doing her work herself. And so she's become more and more anxious. Now she's not well motivated. She is behind, and she's getting increasingly anxious. So I don't believe there's any evidence or history that would suggest attention deficit disorder, but anxiety and certainly depression are there. Substance use is also something that, particularly in kids who have attention deficit disorder, that is untreated and they are referred for other things, including substance use. We, in the past, have been reluctant at times to provide stimulant medications and other treatment because of substance use. And what I think we now believe is that kids who are treated for their attention deficit problems are more likely to not be involved with substances rather than the other way around. Now, that doesn't mean that you're not going to monitor for substance use that may continue on while you're doing treatment for ADHD, because that clearly does happen. But that is certainly something to look for. Bipolar disorder, there has been an association between ADHD and bipolar disorder for many years. It was once thought that 25% of all kids who had ADHD would go on to present with bipolar disorder. And that there was also a strong presentation of ADHD in people already diagnosed with a bipolar disorder. So that is also something to keep in mind. Certainly tics, including Tourette's. We've often said that there seems to be a triad that exists between Tourette's, tic disorder, ADHD, and obsessive compulsive disorder. And so when you see two of those present in the context of anxiety and tics, it's always helpful to go looking for what may be the third presenting part of that. The most important thing I can stress as we go to the next slide is the importance of assessment. The medical consequences of ADHD in children and adolescents, these kids are often risk takers. They're impulsive. It's not uncommon for on the playground, these are the kids who have climbed to the top of the jungle gym or have climbed a tree or have gone out on the roof at home. They tend to be the ones who want to stand up and ride bikes without holding on to the handlebars. And so they tend to be ones who are often seen in the emergency room. We've actually had referrals made by the emergency room physicians who have had these kids in the ER for like the third or fourth time to get stitches or to be examined for possible head injury, and they are extremely hyperactive in the ER. And we've had referrals based on that. Adolescents can also have similar kinds of things as well in terms of accidents and things that are impulsively risky. But they are also often found to be at fault for motor vehicle accidents. So one of the things that I stress to parents as they have children who are enter adolescence and at the age of 15 when they're getting their learning, that it is really important that kids have their medication in order to have adequate attention for driving. University of Virginia did a study several years ago that looked at adolescent accidents and the relationship between their ADHD medications being in their system or not. And what they found was that there seemed to be fewer accidents during the daytime when these kids were typically covered with their morning dose of medication. But if they were not on medication in the later afternoon, it had worn off, or particularly the evening when they were driving, that there seemed to be a strong indication of inattentiveness and perhaps even impulsivity that was associated with it. What was interesting about the study is they actually had people who were involved in the study ride in the car and make observations about some of the kids that they were evaluating for the increase in motor vehicle accidents. And what they noted was kids in the afternoons and evenings off medications driving presented very differently. Lastly, again, I mentioned previously that there appears to be some substance use and possibly even criminal behavior that's due to some risk-taking and impulsivity in untreated ADHD. The next slide. Risk factors. So there are no clear-cut causes of ADHD. It's not as though we've identified something in particular is going to cause it. But there do appear to be some risk factors for ADHD, things that when we see ADHD that are commonly in their history and may be associated with that. Some of the psychosocial are family discord, where there is family violence, a lack of structure in the home, things where, for example, homework and quiet time in order to complete work or have support for that due to family discord isn't present. And there seems to be an association between that and an increase in reported attention deficit disorder. The same would be true also for a lower socioeconomic class. Times of economic stress, paternal criminal behavior, which I'm not sure exactly, but there was some research that suggested when you have that type of behavior, I think it may be, in fact, that there's a parent there who has attention deficit disorder, and their untreated disorder has resulted in their having criminal issues. Maternal mental illness. There's been several studies that have looked at parents who have suffered from depression and other conditions, schizophrenia, and that those conditions increase the presence of many mental health issues in children and adolescents, including things like depression and anxiety and attention span issues. Abuse and foster care. I would really point those out as being very important. One of the things that happens when we see children who have been abused and who come in for referrals, we oftentimes see that there is an element of neglect and mistreatment, and the children are inattentive and they are hyperactive and they are poorly focused and difficult to manage. When they go on to be in foster care, that is a very common referral. And we will get referrals in the clinic where foster parents or DHHR workers who have placed children in a foster home are having difficulty maintaining the child in the foster home. Parents can't manage the hyperactivity, can't manage the risk-taking behaviors, and will request evaluations. Sometimes DHHR will actually request medication because they're trying to maintain the placement. And it's notable that there is a disproportionate number of children who are in foster care, particularly recent foster care, who are diagnosed with many mental health issues, but in particular attention deficit hyperactivity disorder. We see kids who come into foster care who have been previously diagnosed that we think may not have it at all, but are the product of the discord and abuse that they've come from. And over time, will attempt to taper and discontinue medications in order to clarify and maintain the diagnosis. But we also see that where there's foster parents or placements are not really willing to do that and are insistent on medications to, quote, calm down hyperactivity, which, as I said, is unfortunate and results in a diagnosis that may in fact have not. I myself have had the experience of diagnosing children, maybe they were 7 or 8 years old in foster care, seeing them several years later and thinking, why on earth did I ever think they had attention deficit disorder? Well, at the time, they appeared to meet the criteria for that with their hyperactivity, their inattentiveness, their impulsivity, and they seemed appropriate. But then later on, as things changed, as they matured and they were out of those unstable situations, those symptoms cleared. And so that's always important. Developmental factors, alcohol, substance use, including nicotine. We have seen an association between smoking during pregnancy and an increase in the appearance of attention span problems. Certainly alcohol has been associated with learning problems and children who may have hyperactivity. Sometimes children with fetal alcohol will respond to stimulant and traditional treatments, and sometimes they won't. So we think that there may be a factor that alcohol causes that actually looks very much like and probably meets the criteria for attention deficit disorder, but those kids don't always seem to respond to the same types of treatment that we would typically use. In pregnancy, some of the factors may be poor or lacking prenatal care, poor maternal health, as we've mentioned. Premature birth may be a factor, toxemia, preeclampsia, long labor, fetal distress, and as I mentioned before, maternal mental illness. All of those things stress a baby early on and can have some impact even in the care of the baby. It's also important to note that when you have a situation where you have a mother who may be stressed for a variety of reasons, you've got maybe a newborn, maybe you have a child who's not sleeping well and having those difficulties, those bonding issues that are so important may not form well. And accordingly set a pattern going forward of a child who has a lack of bonding to a care provider that can have long-lasting effects regarding things like attention span and learning. So all of those. One of the things that we have been watching is with the COVID-19 quarantine, we are seeing stress on families where not only are they stressed because they're all together and restricted where they can go and what they can do, and the kids are not in school, but there's also significant economic stress in situations and what seems to be an increase in substance use on the part of parents. And so with that seems to be coming an increase in abuse with kids. And so there will be some perhaps long-lasting effects from this quarantine in that regard. Next slide. So the assessment. I started to say how important the assessment is. One of the things that has always been concerning, I think, to those of us who do this work is that there are kids who are overdiagnosed and kids who are underdiagnosed and people who are very unbelieving of the diagnosis, very skeptical of the diagnosis as being legitimate or real. I've had people who made comments, pediatricians, for example, pediatrician who said, oh, I know ADHD. I can tell when those kids come in my office, which ones have it and which ones don't. And so I think that may be why, quite frankly, ADHD gets sort of a bad rap. Because people use it kind of as a descriptor of, oh, he's ADHD, meaning, he's hyperactive or oppositional or disobedient or whatever that is that's going on. But as I have pointed out to many people, the validity of that diagnosis and how accurate that diagnosis is going to be dependent on what kind of quality and thoroughness of the assessment. When we have children who come into, for example, our child clinic, one of the things that they will often be presenting with is they're there to be evaluated for ADHD. And we point out to them that you can't just be looking for ADHD. When you're doing an evaluation and assessment of a child, you're looking at everything. And maybe there's ADHD there and maybe there's not. And maybe you'll find abuse or maybe you'll find anxiety, but your assessment is really, really important. The most important things are getting a history from the parent, and that, of course, includes prenatal history and developmental history, because parents can provide the best description of what children are like. One of the things that's always important is to look at development. Autism is something that we begin to look for through the development. And although it used to be that was excluded, you couldn't have diagnoses of autism and ADHD, the DSM-5 no longer recognizes that as an exclusion. So you can have both. And so it's always important that you're getting all that information. And you also need to get history from the teachers. What are their grades like? What is their behavior like? There are a number of rating scales that teachers can fill out. And not only are they useful as you're making the assessment for a diagnosis, but they're extremely useful as you're monitoring the reaction and the progress of medication. I think that they're important, particularly when there are occasions at times when the report of parents and teachers don't match. I have a parent that's there, and I've got a questionnaire where they filled out a Connors or some other type of rating scale, and they have endorsed to the extreme every element of hyperactivity, won't sit still, won't do their work. I mean, just right down the line. Then I'll get one from a teacher, and the teacher has very little to comment on regarding that behavior. So it's important, because we want to come up with at least 2 or more settings for this diagnosis to be in place. It's important that I figure out how to reconcile those 2 very different reports of that child's behavior, and there can be a number of reasons for it. It can be that the parent is really overly endorsing, that this is a parent who has very little tolerance for the behavior. The school, on the other hand, is structured and reinforces and does a better job of managing that behavior. It can also be that the parent is actually accurately reporting what's going on, and the teacher is underreporting. I've had teachers who, when I spoke with them, what they described in person to me pretty much met attention deficit disorder. But the teachers were quick to tell me, I don't believe in ADHD, or I don't believe in medication. And I didn't want to endorse those things because I was afraid the parent was going to go put them on medicine. So sometimes there is a difference between the rating scales, and it is important to resolve that and to reconcile that, and also to use that for ongoing monitoring. An example of the monitoring usefulness is the report between the parent and the teacher are very much in agreement. We start the medication, we increase it. The parent insists that they still need more medicine. It's not enough. They want more medicine. The report from the teacher is, no, they're actually doing well. And so you want to reconcile, what's that about? Is the parent reporting in the evenings, or do they not see the child when they're on medicine? Or is there some other reason why the parent is trying to get medicine increased, either for diversion or their own reasons? So that monitoring is really important. And it's helpful sometimes to, talk to the teachers, get a release of information at the very beginning so that you can get that information and talk with them. Medical assessments are important. We don't necessarily do it as a routine matter, but working with a pediatrician or the primary care provider, if you're a specialist that's doing this, it's important that you know about their medical care. And if they have any issues that may point to problem areas such as thyroid, or do they have asthma, something that may in fact be contributing to attention span, or something else. One of the things that I have a lot of people say is, well, we need to refer them for a psychological, or we need to refer them more specifically for a neuropsychological evaluation. Those evaluations are helpful when you are looking at particularly learning problems and learning disabilities. They also can help identify what the strengths are and what the relative weaknesses are. And they can be very helpful if you're going to be working towards some help from the school system that I'll talk about in a minute. But they're not diagnostic, and you're really not going to be making a diagnosis based on that. But they can be helpful. But certainly, I'm not going to make a diagnosis of ADHD based on that. Not also helpful would be computerized tests, brain imaging, routine labs, unless you think that they have some type of lead difficulty. Genetic testing, also not necessary or helpful. Routine EKGs, typically unnecessary and not recommended for starting medicine. And routine EEGs are not necessary unless you have a teacher reporting staring spells, which are representative of the poor attention span, and may suggest some sort of type of seizure, and that will prompt a neurologic assessment. Next slide. So treatment, finally, and at last I'll get to this. So the initial treatment really is more than medication. It is important that the care provider, parents understand what ADHD is and what it is not. That it is not brain damage. It doesn't mean that they're going to be forever crippled by this diagnosis. And it's important that they understand the nature of it as well as the treatments. So we provide education to the parent, but we also provide it to the child. Because I've had kids tell me, it wasn't really my fault that happened because that was my ADHD kicking in. I've literally had them tell me that. They also tell me about their bipolar disorder too, that it kicks in and causes them to misbehave. Family treatment is important. Sometimes parents will greatly benefit by parent training and parent-child training. We use parent-child intensive training, which is very helpful. And that helps parents with the challenges of an ADHD child. School focus is important. They may qualify for an individualized education plan, particularly if there are other learning disabilities present or IQ issues. And a 504 plan, which is the American Disabilities Act, can provide for assistance and help and all sorts of things that can be incorporated into a plan to assist that child. The point of all of this is that medication is not the complete and only answer for this, and we have to utilize other things, such as I've included there at the bottom, social skills training, help with the organization, and adults in particular benefit from CBT therapy. Next slide. So, medication. There is no magic medication. Parents will come in and they will say things to me like, I want whatever that best medication is. I want the medicine that's going to treat them but has no side effects. They will also tell you things like, I don't want him on Ritalin, or they'll name something specific. Whenever parents come in and they have specific concerns about a medicine, my general focus is to ask them, tell me what you know about that. Tell me what your source of information is, so I can better understand what it is that's influenced your thinking. That's very important because oftentimes you'll find out that it is the internet, it's their next door neighbor, it's some friend who had a son who went crazy on Ritalin, any number of factors. So education is really important, and to be able to do that well, you really need to understand what level they have. In general, with medications, we're focusing on two neurotransmitters, dopamine and norepinephrine. The primary focus is stimulant medication. Stimulant medicines, particularly Ritalin, is the most studied medication for children in the world. When it works, it is effective. And with ADHD, stimulant medication will be effective in about 70 to 75% of the cases. And so using that is not something that I avoid, although I'm certainly respectful of parents who say, I'd like to try other things first before we use medication. And the younger the child, the more true that's going to be. We're going to try a number of things before we necessarily go to medication in really young children. What I would say in general is we try to use long-acting medications so that there don't have to be multiple doses during the day. The issue with that is the fact that you get a wear-off effect, and then you have to give multiple doses, which are forgotten or the kids don't want to take, and then you get breakthrough issues in between. So we do try to use long-acting, but oftentimes it's not enough to get through homework or afternoon or evening things, and so we sometimes give a supplemental dose of short-acting. I do have patients and have had patients who would have absolutely benefited from a long-acting medication in the morning and a second long-acting dose at 3 or 4 o'clock in the afternoon. Occasionally, I will have an insurance that will pay for that. The vast majority will not. And so we do oftentimes supplement with short-acting. This is not necessarily true for children and adolescents, but it's certainly true for adults. Always have a high index of suspicion when you have someone, an adolescent as well, who can't take long-acting medications and can only do well when they have multiple doses of short-acting, because that is certainly a red flag for substance use, abuse, and diversion. And so that's always something to do. But there are some patients, particularly the younger ones, who do much better when they have small doses of immediate release. But again, just as a warning, keep in mind that that may be an issue. Next slide. The primary side effects of stimulants are a decrease in appetite, difficulties with some growth delay, some mood issues, crying spells, particularly in the afternoon when the medications wear off. Kids will also have a rebound in their hyperactivity in the late afternoon when the medicine is worn off, and you need to watch for that. They also can have tics, which you can reduce dosages and kind of monitor, and sometimes that will do it. Sometimes you will switch medications and go to a different stimulant or supplement, but they can generally do well actually with stimulants. One of the important things is to find out at the very beginning, do they have any growth issues? Only to find out later on, oh, well, yes, he was diagnosed with growth hormone deficiency, when you're, really worried about the lack of growth in this child. Sleep, are they a good sleeper? Are they a good eater? Because kids who have good sleep and good eating tend to not have as many problems with stimulant medications. But it is important so that 6 months in, when you're trying to deal with their sleep problems, only to find out, oh, heck, he hasn't slept since he was a newborn. So those are important things, as well as picky appetite. In addition, very quickly, to stimulant medications, there are a couple of other classes of medicine we use. One is atomoxetine, which is Strattera. It has been used, I think, primarily for inattentive type. I have not found it personally to be helpful in a really hyperactive child. Inattention seems to be its primary thing, and we use it if we want to avoid stimulants. Parents sometimes will prefer it. There are some issues with atomoxetine. It is something that is a weight-based medication. The ideal is around 1.2 to 1.4 milligrams per kilogram, but that's not a hard and fast rule. And some children don't tolerate it well at all, particularly at higher doses, because of GI complaints and dosage and nausea. The thing to remember with Strattera, it's not a stimulant, and you are not going to see a response in a week. It is going to take some time, if in fact that it works at all. With respect to that and all of these medications, the rule generally is to start at a low dose and move up as it is tolerated, which you can generally do within a week, 2 weeks certainly, as you're beginning to see what the response is. I think this is the next slide, but the last slide, yeah. The last one I'm going to mention are the alpha-2 agonists. Sometimes people will use the short-acting form of clonidine at bedtime for sleep. Actually, the long-acting form of the alpha-2 agonists, both guanfacine and clonidine, show helpfulness with attention span. The clonidine long-acting, which is Catve, which comes in 0.2, 0.3, 0.4 milligrams, has a little more sedation associated with it than the guanfacine, but it also is long-acting, and again, beginning low and slowly increasing. The long-acting form of that trade name is Intuniv, and that can be increased to 1, 2, 3, and 4 milligrams. The last thing I'm going to mention has to do with changing medications. I don't know if you all who prescribe medication have had this experience, but I'll have a child who's on a medication and doing absolutely great, perfect. They've been on it for a year, no problems at all, and the Medicaid formulary changes. And I am now trying to change them from one that is no longer covered by Medicaid to a different medication. What I recommend, if you're simply trying to change and move dosages, that there is actually a really good, and I'm going to give you the name of it, a really good table that I use and several of my colleagues use that helps you change within those classes to get the dosages sort of an equivalent. It's approximate, but it's pretty close. It is actually available from the Cohen, and I'll provide this address in a little bit, and then they can send it out to you. It's the Cohen Children's Medical Center. And they actually have a website, and you can order this. It's really nice. It comes laminated, and we use it a lot. It's handy. What I would say that it is not as handy for is if you've had someone who's not tolerating a medicine or hasn't done well on it, and you're going to need to change. That typically is not going to be a direct switch, but rather a discontinuation of the first medicine and then a gradual starting an increase of dosage in the new medication. And so that's generally not going to be. But it's also good because it gives you a complete listing of the FDA-approved medications that are long and short-acting, as well as the doses. So it's a really good reference tool. And I would have put it on the bottom here, but I completely forgot until I got ready to do this presentation. So I'll be glad to provide that to you. So, questions? That was a lot, I know.
Oh, thank you so much. That was excellent. And thank you again for that resource for the table. If you would like, you can email me the link and I'll provide it in the recap email for everyone.
Be happy to.
Thank you. So are there any questions for Dr. Goody-Coons? Feel free to chat them in as well. I know we had a question come in asking how your experience has been with COVID and treating patients through telehealth.
So it's really been kind of a mixed experience for me. In fact, I'm getting ready to do an interview over the phone with a newspaper who's asking me similar questions. What I've found is with the older adolescents, and even some of our tween kids, our 12 and 13-year-old kids, they're used to video and Skype, and so they are far more comfortable. And I think that it's much easier to talk with them, and they're comfortable and they don't have a problem. The smaller children are a bit of a challenge. It's difficult for them, to sit still and to pay attention. And so I found that although I see them and I get a glimpse of them, to be honest with you, I do end up spending a lot of time with the parent. What I think is really not possible for me, and I haven't heard anybody else who's really felt they've done well with it, is to do a new evaluation of a child or a younger person. The adolescents, I think you can get some information if they're old enough and they're able to do it, but I cannot recommend using, at least in my experience, someone who's a little more hyperactive and try to get them to do a video. It's a lot more challenging.
Right, absolutely. I can only imagine. Thank you for that. So we got a question in through the chat. Is there a way to refer for parent training? My patient population has great need for this, but resources seem limited.
I would say that the best, depending on your area, to check with either something like WVU or one of the community mental health centers and ask them if they provide parent training. We certainly do for the PCIT, which the parent and the child are in like a group room and they're doing an activity. The parent has an earpiece and the therapist is sitting on the other side of a glass partition so that they can't see them, but the provider can see them, and then we'll often make prompts and comments to help guide the parent in their interactions. This is typically for younger kids, and it works well. I think for kids who are older, I think certainly seeing a therapist to deal with a challenging child is helpful. I also would say that if the child is being seen by a therapist or by a psychiatrist, that I would talk with them about getting some assistance with that. And if they're seeing the individual for medicine who asked the question, then your best is to check with your resources and simply ask them, is this something you provide?
Perfect. Thank you so much. Any other questions for Dr. Goody-Coons or your personal experiences that you'd like to share. And of course, like always, if there are any other questions anyone thinks of after the fact, just email them over to me. I'll make sure to have them addressed. So I don't want to hold anyone longer than we have to, but just a quick announcement. So our next session will be on June 3rd, and Dr. Swagger is providing our didactic on specialty conditions. So thank you so much, Dr. Goody-Coons, for the excellent didactic today. We really appreciate it. And see you all next time.
Mhm.
Thank you. Bye.
Bye.